Usually when we talk about a medical diagnosis, there's this comforting expectation of precision. It feels almost like engineering, right?
Exactly.
Like if you fall off a bike and break your arm, you go to the hospital, the doctor throws the x-ray up on the light board, and there it is, just that jagged white line.
Right. They just point at it and say, there's the problem.
Yeah.
It's very binary.
Yeah. Broken or not broken.
Infected or not infected.
Yeah.
I mean, human beings love binary systems. It gives us a very clear enemy to fight and a clear path to fixing it.
Exactly. It's clean. But then, you step out of the emergency room and into the world of genetics and oncology, and suddenly that metaphorical x-ray machine feels, well, completely useless.
Yeah, it really does.
You're looking at a diagnostic landscape that is entirely invisible to the naked eye. And honestly, for you as the listener or even for seasoned doctors, it can feel incredibly murky.
Murky is a great way to describe it, actually. We are dealing with biological cascades that happen on a microscopic level, often decades before a patient ever feels a single symptom.
Right.
So it requires a completely different way of thinking about medicine.
Well, welcome to this deep dive. Today's mission is to unpack a condition that sits right at the center of that murky, invisible world. It's a complex, fascinating, and frankly high-stakes medical topic, familial adenomatous polyposis, or FAP.
This is a massive topic.
It really is. And whether you are someone who is just intensely curious about the hidden code of our DNA, or, perhaps you're a medical professional actively prepping for your FRCS clinical Viva exams, this conversation is custom-tailored to give you the ultimate high-yield overview.
We have a lot of ground to cover for those exams. Yeah.
We do. We've got a truly massive stack of medical literature on the table today to guide us. We're pulling insights from the comprehensive clinical guidelines published by NINES, detailed pathology breakdowns from Stat Pearls, surgical strategy updates straight from the clinics in colon and rectal surgery, and even this brand new, just fascinating genetic case study from Spandito's publications.
Looking at the stack of sources, the very first thing that jumps out is just how fiercely multidisciplinary this condition is.
Right. It's not just one doctor.
Not at all. If you are a patient dealing with FAP, you are navigating a vast team. It requires a gastroenterologist to scope the gut, geneticists to map the DNA, colorectal surgeons to perform life-altering operations.
And oncologists to manage the cancer risk.
Exactly. All of them having to communicate flawlessly.
So let's set the baseline for everyone listening. What actually is this disease? At a high sort of 30,000-foot view, familial adenomatous polyposis is a hereditary condition where hundreds, and very often thousands, of precancerous polyps completely blanket the lining of the large intestine.
A literal carpet of them.
Yeah, and if this condition is left untreated, the progression from those polyps to full-blown colorectal cancer is virtually 100%.
Which is a terrifying statistic.
It is. It's not a matter of if, it is a matter of when. But, as we're going to explore deeply today, treating FAP is not simply a matter of removing a colon and calling it a day.
Far from it.
Right. It's a systemic whole-body genetic syndrome. It forces doctors to play an incredibly complex game of chess with the patient's own biology.
And to really understand the rules of that chess game, we have to start at the very beginning. I mean, before we can even begin to talk about how a master surgeon decides to remove an organ, we have to zoom all the way down.
Down to the cells.
Past the organs, past the tissues, right into the microscopic architecture of the cells themselves. We need to understand the exact moment the brakes fail on human cell division.
Let's do it. So, looking at the genetic pathology here, the sources point to one massive culprit for classic FAP. It's a germline mutation in a very specific gene called the APC gene.
Which stands for Adenomatous's polyposis coli.
Right. Now, the literature states this is located on chromosome 5q2122. For those listening who might not, look at karyotypes all day, what does that string of numbers and letters actually mean?
It's basically a microscopic street address. Human beings have 23 pairs of chromosomes, which are the tightly coiled structures that hold our DNA. The 5 means we're looking at the 5th chromosome pair.
Okay, simple enough.
Right? And every chromosome has a short arm, labeled P, and a long arm, labeled Q. So 5q tells us we are on the long arm of the 5th chromosome.
And the 2122.
That refers to the specific bands, or like the neighborhoods, on that arm where the gene resides. So if a geneticist is looking for the root cause of classic FAP, they drive straight to chromosome 5, head down the long arm, and look at bands 21 and 22.
I love that. We have the address. Now, what does the resident of that address actually do for a living? Like, when the APC gene is healthy and functioning normally, what is its day job in our bodies?
Its day job is keeping you alive, honestly. It acts as what we call a gatekeeper tumor suppressor.
A gatekeeper?
Yeah. To understand this, you have to realize that your cells are constantly dividing, dying, and being replaced. The lining of your colon, for instance, replaces itself entirely every few days.
Wow, every few days.
Yeah, it's highly active tissue. The cells are born deep in the tissue, they migrate up to the surface, they do their job absorbing water, and then they're supposed to die and slough off to make room for the new cells coming up from below.
And that planned, orderly death has a specific name, right?
Yes, apoptosis. It's programmed cell death. It's essential. Now, the APC protein is basically the manager of this process. Specifically, it manages another crucial protein called beta-catenin.
Okay, beta-catenin, what does that one do?
Beta-catenin is essentially a cellular messenger. When it is active, it travels into the nucleus of the cell and delivers a message that says, hey, we need to grow, we need to multiply, keep dividing.
So beta-catenin is the accelerator.
Precisely. It is
Yeah.
constantly pushing for growth.
Mhm.
In a healthy cell, the APC protein binds to beta-catenin and essentially tags it for destruction when the cell doesn't need to divide anymore.
Ah.
APC is the supervisor saying, okay, we have enough cells here, beta-catenin, you need to stand down. It actively prevents beta-catenin from entering the nucleus.
But if a patient has a mutation in the APC gene,
Then that gene produces a broken, non-functional APC protein. The supervisor goes permanently missing on the job.
so without APC there to tag it and destroy it, beta-catenin just builds up.
It accumulates massively, it floods into the nucleus, and it continuously shouts that message: divide, grow, multiply. The cells receive this endless growth signal, and crucially, they forget how to die.
They lose that programmed apoptosis.
Right, because they aren't dying and sloughing off naturally, they just pile up on top of each other. And that pileup is what forms those small, initially benign growths on the colon wall that we call adenomatous polyps.
I want to make sure this is crystal clear for everyone listening, so let me try an analogy here. If the entire process of human cell division is a car, the beta-catenin protein is the engine constantly pushing the car forward, right?
Yes, perfect.
The APC gene, then, is the brake pedal. In a healthy person, you use the brake to control the speed and stop when you need to. But in a patient with FAP, that mutation means the brake line has been completely severed.
That's exactly it.
The car is accelerating down a mountain, and there's absolutely no mechanism left to stop it from eventually crashing into a tumor.
That is a phenomenal way to visualize it. The cellular machinery is speeding up, and while those initial polyps are benign, it's only a matter of time before that uncontrolled division leads to more genetic errors.
Yeah.
And that transforms the benign polyp into a malignant carcinoma.
That is the classic pathway.
Yes. But here is where top medical professionals, especially those prepping for exams, have to be really careful, because the sources highlight a second distinct genetic culprit that can look almost identical clinically.
Oh, right. We are talking about the MUTYH gene, which causes MUTYH-associated polyposis, or MAP.
Exactly.
And this one doesn't live on chromosome 5. It's located way over on chromosome 1. Now, if APC is our broken brake pedal, how does the MUTYH mutation actually cause these polyps? Because the mechanism is entirely different, isn't it?
It is fundamentally different. The MUTYH gene has absolutely nothing to do with beta-catenin or growth signaling. Instead, the MUTYH gene writes the recipe for an enzyme called MYH glycosylase.
Okay, what does that enzyme do?
Its sole purpose is DNA repair. It is a microscopic proofreader.
Proofreading what exactly?
Proofreading the literal letters of your DNA. During normal, everyday cellular life, your DNA is exposed to metabolic stress. One of the most common stressors is oxidative damage.
Just from breathing and living.
Exactly. Simply processing oxygen can alter one of the base pairs of your DNA, specifically guanine. When guanine gets oxidized, it changes shape slightly. So when the cell tries to copy its DNA to divide, that altered guanine accidentally pairs up with the wrong partner.
It pairs with adenine instead of cytosine.
Right. It is a biological typo.
And normally this MYH enzyme would spot that typo and fix it.
Yes, through a process called base excision repair. It scans the DNA, recognizes the mismatched A and G, cuts out the wrong letter, and pastes the correct one in. But in a patient with MUTYH-associated polyposis, that proofreading enzyme is defective or just completely absent.
Let me see if I can adapt our car analogy for this one. If the APC mutation is a broken brake pedal that causes an immediate uncontrolled crash, is the MUTYH mutation more like having a blind mechanic in your pit crew?
Ah, I like that.
Like, the car's engine and brakes work fine initially, but when small, inevitable wear and tear happens, the blind mechanic can't see the broken parts to fix them.
That is the exact distinction. With the blind mechanic, the car might run perfectly fine for the first few miles. But because the routine maintenance isn't happening, errors start to accrue. The typos in the DNA compound over time.
And eventually.
Eventually, those compounded errors strike a critical gene, perhaps even the APC gene itself, and that initiates tumor formation. The end result inside the colon looks incredibly similar, a carpet of dangerous polyps. But the molecular failure that brought the patient to that point is entirely different.
Which feels like it should be just, I don't know, a bit of academic trivia. Who cares how the car crashed as long as we treat the crash, right?
You'd think so, but no.
Right, because the sources make it explicitly clear that understanding this molecular difference changes everything about how the disease is inherited in families. If you are sitting down with a genetic counselor, the difference between APC and MUTYH alters the entire conversation.
It dictates the entire future of that patient's family tree. Let's look at classic FAP, driven by the APC mutation. This is an autosomal dominant condition.
Dominant meaning?
Meaning that the mutated gene is so powerful that you only need to inherit one single broken copy from one parent to develop the full-blown disease.
So if a patient has classic FAP, every single time they have a child, there is a coin flip. A 50% chance that the child will inherit the mutation and face a 100% risk of colon cancer.
Exactly. It's a terrifying coin flip. However, there is a crucial clinical pearl here, something that routinely trips up junior doctors and is a massive focal point in advanced exams like the FRCS.
Oh, let's highlight this for the exam preppers.
You cannot assume that just because a patient's parents are perfectly healthy, the patient cannot have FAP.
Because of de novo mutations.
Yes. The literature shows that roughly 20 to 30% of all classic FAP cases are de novo, meaning from new. The mutation did not come from the mother or the father.
It just happened spontaneously.
Spontaneously in the sperm or the egg, or very shortly after conception. The patient is the very first person in their family's history to have this broken brake pedal. If a doctor dismisses a young patient's symptoms just because there was no family history of colon cancer, they could be making a fatal error.
Wow. Okay, so that is the inheritance reality for APC. How does it contrast with the blind mechanic, the MUTYH gene?
MUTYH-associated polyposis is autosomal recessive. Recessive means the broken gene is, well, weak. If you inherit one mutated MUTYH gene from your mom, but a perfectly healthy MUTYH gene from your dad, the healthy gene steps up, does all the proofreading work, and you are fine.
You are just an asymptomatic carrier.
Exactly. To actually develop the disease, you must inherit two broken copies, one from your mom and one from your dad.
So, imagine you're the genetic counselor sitting across from a newly diagnosed patient. How does the math change when you explain the risks to their family?
It's a profound shift in the tone of the room. If you are counseling a patient with a dominant APC mutation, you have to deliver heavy news. Your siblings have a 50% chance of having this, and every child you ever have will have a 50% chance.
That's heartbreaking.
It is. But if you discover the patient actually has MAP, the recessive condition, the conversation is very different. You tell them, your parents were likely just silent carriers. Your siblings have a 25% chance of having inherited both copies like you did.
And what about their kids?
You tell them, your children are only at risk if your partner also happens to be a carrier of this exact same mutation.
Which is incredibly rare in the general population, right?
Very rare. So you can often look at an MAP patient and assure them that while their own health needs strict management, their future children are overwhelmingly likely to be perfectly safe. It lifts an immense psychological burden off the patient.
That is wild. The exact same symptoms, the same polyps, but because of a molecular nuance on chromosome 1 versus chromosome 5, the entire legacy of the disease changes.
It really does.
Now, before we move out of the DNA and into the physical colon, there's one more genetic concept the sources hammer on, and it's fascinating. Genotype-phenotype correlations.
So this is where genetics starts to feel almost like reading tea leaves, but with clinical precision.
Right. So genotype is the literal code, the specific location where the DNA broke. And phenotype is how that break actually manifests in the physical body, like how many polyps grow, at what age, and where.
Yes.
Basically, the sources are saying that where the gene breaks dictates how the disease attacks you.
Precisely. The APC gene is not a small, simple switch. It's a massive, complex structure containing 15 coding exons. You can think of it like a very long instruction manual. Depending on which specific page of the manual gets torn out, the resulting protein malfunctions in different ways.
And we know which pages do what.
We've mapped this meticulously, yeah. For example, if the mutation occurs right around a specific location called codon 1309,
Let me guess, that's a bad neighborhood for a mutation.
it is one of the worst. A mutation at codon 1309 correlates with a devastatingly profuse polyposis phenotype.
So tons of polyps.
We are talking about thousands upon thousands of polyps appearing extremely early in life, often in early childhood. The progression to cancer is aggressive and rapid.
But what if the manual gets torn at the very beginning or the very end?
That changes the phenotype entirely. If the mutation occurs at the extreme ends of the gene, the 5' end or the 3' end, or in a specific section called exon 9, the resulting APC protein isn't completely destroyed.
It still works a little bit.
It retains a small amount of its tumor-suppressing function. The brakes still squeak and offer a little resistance. This leads to an attenuated form of FAP, which is a much milder physical presentation that we'll discuss in detail shortly.
This all sounds so neatly categorized. You look at the codon, you predict the disease. But this is medicine, so nothing stays neat for long.
Very true.
Which perfectly sets up that new case study from Spandita's publications. When I read this, it completely upended how I thought about genetic testing.
It's a landmark case for understanding just how elusive FAP can be.
Yeah.
Usually when we sequence a patient's DNA looking for these mutations, we focus our attention heavily on the coding regions, those 15 exons that actually provide the direct recipe for the APC protein.
Right. It makes logical sense. If you want to find a typo in a book, you look at the text.
Exactly. But our DNA is full of stuff that isn't the direct text. For decades, early geneticists arrogantly dismissed massive portions of our DNA as junk DNA simply because it didn't directly code for a protein.
But we now know those regions are incredibly important regulatory regions.
Yes, they act as volume knobs, turning the expression of the coding genes up or down.
So what happened with the patient in this Spandita's case?
This is a 63-year-old patient who presented with the classic terrifying phenotype of FAP. Their colon was carpeted in adenomatous polyps, and they had progressed to colorectal cancer. Clinically, there was no doubt they had FAP.
Okay, so the phenotype was obvious.
But when the doctors ran standard genetic panels looking at the usual coding regions of the APC gene, they couldn't find the smoking gun.
The street lamps were shining, but the keys weren't under them.
Precisely. So the researchers had to cast a much wider net. They looked far outside the normal diagnostic parameters, deep into an upstream, non-coding regulatory region of the DNA.
And what did they find?
There, tens of thousands of base pairs away from the actual gene, they found a rare variant denoted as C30266GA.
Now here's the twist that makes this case report so important for clinicians. Finding a mutation upstream isn't totally unheard of, but this specific mutation had a very particular reputation, didn't it?
Yes. Previously, the medical community believed this specific upstream mutation almost exclusively caused a very different, highly specific phenotype known as GAPPS. That's gastric adenocarcinoma and proximal polyposis of the stomach.
It's a stomach cancer.
Right. In GAPPS, the mutation devastatingly impacts the stomach lining, causing massive polyp growth and stomach cancer, but typically leaves the colon relatively spared.
But this 63-year-old patient
Had absolutely no gastric involvement whatsoever. Their stomach was clear. Instead, this mutation, which historically targeted the stomach, caused classic textbook familial adenomatous polyposis in the large intestine.
If you're a doctor or someone studying to be one, what is the core takeaway from this? It feels like it shatters the rules of genotype-phenotype correlation.
It doesn't shatter the rules, but it proves the rulebook is much thicker than we thought. It tells clinicians that our genetic testing panels must evolve.
You can't just test the obvious spots.
No, you cannot just test the obvious coding regions and tell a patient they are safe if the test comes back negative. Mutations in the dark matter of our DNA, the non-coding regulatory elements located vast distances from the gene itself, can profoundly alter the dosage of the APC protein and trigger the full, deadly cascade of classic FAP.
Wow.
If the clinical evidence in front of your eyes says polyposis, but the genetic test says normal, you trust your eyes and you dig deeper into the DNA.
That is an incredible transition point for us. We've spent all this time in the invisible realm of genetics, looking at broken breaks, blind mechanics, and mutations hiding in the dark matter. But if you are a patient, you don't feel a mutation on codon 1309.
No, you don't.
You feel the physical reality inside your body. So, if that is the genetic blueprint, what happens when a gastroenterologist actually takes a camera and looks inside the gut? Let's dive into the clinical subtypes and timelines, starting with the heavyweight classic FAP.
Visually, a colonoscopy of a patient with classic FAP is one of the most striking and unmistakable sights in gastroenterology. A healthy colon lining should look smooth, pink, and vascular. But in a classic FAP patient, the normal mucosa is completely obscured.
The sources describe it as a carpet.
That is the most accurate term. The diagnostic threshold is typically cited as having more than 100 adenomatous polyps, but the clinical reality is that it is very often hundreds or even thousands of these polyps covering every square inch of the large intestine.
And what do they look like?
They vary in size from tiny millimeter-wide bumps to large pedunculated polyps that look like mushrooms growing off the colon wall.
And the timeline for this growth is aggressively fast. I mean, if you're listening and thinking colon cancer is a disease of people in their 70s, FAP entirely rewrites that schedule.
It shifts the timeline violently forward. The polyps typically begin to appear in early adolescence. The average age of onset is around 16 years old.
16.
Yes. This means a high school sophomore is already growing hundreds of precancerous tumors. And because the sheer volume of polyps is so high, the statistical probability of one of them acquiring the necessary secondary mutations to become malignant is immense.
So if a teenager with classic FAP slips through the cracks, maybe they live in a rural area, maybe they don't have access to screening, and no surgical intervention ever takes place, what is the inevitable outcome?
The outcome is grim. Without prophylactic surgery, the progression to colorectal cancer is virtually 100%. It is not a possibility, it is a certainty. And it strikes mercilessly early. The mean age for developing colon cancer in an untreated classic FAP patient is just 39 years old.
That is absolutely horrifying, 39. Now, earlier we talked about how a mutation at the extreme ends of the APC gene leaves the brakes partially working. This causes the second major subtype, attenuated FAP, or AFAP.
Right.
If a gastroenterologist scopes an AFA patient, how does that visual differ from the thousands of mushroom polyps we just talked about?
It's a much more subtle presentation, which actually makes it far more dangerous diagnostically. Because the APC gene retains some tumor-suppressing function, the polyp burden is significantly lower. You aren't looking at a carpet. You typically see somewhere around 30 polyps, and by definition, it is almost always fewer than 100.
Okay, so just a handful of polyps. That sounds easier to manage, but you said it's more dangerous diagnostically. Why?
Because of how and where they grow. In classic FAP, the polyps are everywhere, and they're usually raised and obvious. In attenuated FAP, the polyps are very often flat.
Oh, I see.
They don't protrude much above the normal tissue line, making them incredibly difficult to spot with a standard endoscope camera if the doctor isn't looking incredibly closely.
They camouflage themselves.
Yes. Furthermore, they have a bizarre geographical preference within the anatomy of the bowel. In classic FAP, the rectum and the left side of the colon are heavily involved. But in AFA, the polyps tend to cluster almost exclusively on the right side of the colon.
Specifically, the sources note they cluster proximal to the splenic flexure.
Right. Let's translate that for anyone who is an anatomist. Imagine your large intestine like a giant square frame bordering your abdomen. It travels up the right side, across the top, just under your ribs, and down the left side.
Okay, got the visual.
The splenic flexure is the sharp hairpin turn the colon makes on the upper left side, right near your spleen, before it heads downward. Proximal means before that point. So AFA polyps hide out deep in the early parts of the colon, way over on the right side.
Which means if a doctor tries to do a quick sigmoidoscopy, which is a shorter camera that only looks at the bottom left side of the colon, they will see absolutely perfectly healthy pink tissue.
Exactly.
They will completely miss the polyps hiding around the corner on the right side.
It gives a false negative, which can be fatal.
And because the genetic brakes are partially working, I'm assuming the timeline for AFAP is delayed compared to the classic version.
It is significantly delayed. The polyps usually don't start appearing until adulthood, often not until the patient is in their 30s or 40s. Consequently, the average age for the onset of colorectal cancer gets pushed back to around 50 to 55 years old.
You know, hearing the word attenuated and delayed timeline, it's really easy to feel a false sense of security. It sounds like the diet version of FAP.
That is a dangerous mindset that medical professionals must actively counsel patients against. Attenuated does not mean safe. The lifetime risk of developing colorectal cancer, if you have AAP, is still estimated to be around 70%.
Wow, 70%.
A 70% guarantee of cancer is still a massive medical emergency. The delayed timeline doesn't remove the threat. It merely changes the surgical management strategy. It allows doctors to hold off on removing the colon in a teenager, but the threat remains very real.
If you are listening to this, whether you are studying for your boards or just fascinated by the human body, it is incredibly easy to get tunnel vision right now. We've talked entirely about polyps and colons.
Right, it's in the name of the disease.
Exactly. The colon is the primary battleground. But if you are a top-tier physician, you know that fixating solely on the colon is a fatal error.
It's the easiest trap to fall into. FAP has the word polyposis right in the name, so doctors hyperfocus on the gut. But the APC mutation is in every single cell of the patient's body. The loss of that tumor suppressor function echoes everywhere.
Which brings us to the systemic threats, the extracolonic manifestations. The invisible mutation leaves footprints all over the body long before a single polyp grows in the gut. Let's start with one of the most bizarre and fascinating diagnostic clues in all of medicine, the eyes.
Yes, we are talking about congenital hypertrophy of the retinal pigmented epithelium, which is mercifully abbreviated as CHRPE.
Let's unpack CHRPE. If you are an eye doctor looking into a child's eye, what are you actually seeing?
You're looking at the retina, which is the innermost coat at the back of the eyeball that senses light. In a patient with CHRPE, the ophthalmologist will see these highly distinct hyperpigmented lesions.
What do they look like?
They essentially look like flat, dark brown or black freckles scattered across the retina.
Does having freckles on your retina cause blindness? Like, does the child notice this?
No. And that is what makes them so insidious as a diagnostic tool. They cause absolutely zero visual impairment. The patient has no idea they are there.
But the doctor can see them.
Right. If an ophthalmologist dilates the eyes of a young child, say a 10-year-old, and spots these lesions, particularly if they are bilateral in both eyes and multiple, alarm bells should be ringing violently.
Because it's a massive red flag for FAP.
It is a highly specific marker. If a child comes from a family with a known history of FAP and they have these retinal freckles, it is a near certain clinical indicator that they inherited the APC mutation, years before any colonoscopy would be appropriate.
Wow.
And tying it back to our earlier discussion about genotype-phenotype correlations, the literature points out that CHRPE is highly associated with APC mutations that occur specifically between codons 457 and 1444.
So you look deep into a child's eyes, you see the freckles, and you know the genetic bomb is ticking. But the true danger outside the colon doesn't lie in the eyes. It lies further up the digestive tract. Let's talk about the upper gastrointestinal hazards.
The upper GI tract is an absolute minefield for FAP patients. As we travel up from the colon, we first hit the stomach. The vast majority of FAP patients, around 90%, will develop hundreds of tiny gastric polyps.
That sounds bad.
Well, the good news here is that these are typically fundic gland polyps. While they look terrifying in a scope, they are overwhelmingly benign and have an extremely low rate of turning into gastric cancer in classic FAP.
But then you move just a few inches past the stomach into the duodenum, the very first section of the small intestine, and the periampullary region where the bile duct empties into the gut.
And the narrative changes entirely. The adenomas that grow in the duodenum and the ampulla of Vater are incredibly dangerous.
Yeah.
They have a high rate of malignant transformation.
And this leads to what I think is the most grim but vital clinical reality in the entire stack of sources today. It is the tragic irony of successfully treating FAP.
Yes. In the modern era of medicine, we've become incredibly proficient at performing prophylactic colectomies. We catch the disease early, we surgically remove the colon, and we completely eliminate the risk of colorectal cancer. The patient survives. But because we saved them from the colon cancer that would have killed them at age 39, they live long enough to face the delayed extracolonic manifestations of the disease.
The threat just moves up the road.
Exactly. Today, because colon cancer is prevented, duodenal and periampullary cancer has become the leading cause of cancer-related death in FAP patients.
That is just brutal.
It is. This is why top gastroenterologists insist that upper endoscopies, passing a camera down the throat to monitor the stomach and small intestine, are just as critical for lifelong survival as the colonoscopies were.
Okay, I want to touch on two specific clusters of symptoms that the sources mention, largely because they love to show up on medical board exams: Gardner syndrome and Turco syndrome.
Right, these are historically older classifications. They were named before we fully understood that a single APC gene mutation was the root cause of everything. They describe specific dramatic combinations of symptoms.
What does a patient with Gardner syndrome look like?
Gardner syndrome is defined by the classic profuse colonic polyposis, combined with prominent visible manifestations in the bones and soft tissues. Patients develop benign bone tumors called osteomas.
Where do those usually grow?
very often in the skull and the mandible, or jawbone. In fact, a dentist might be the very first medical professional to suspect an underlying genetic condition because Gardner syndrome patients frequently have profound dental abnormalities.
Like what?
They might have severely impacted teeth, supernumerary or extra teeth growing in odd places, or odontomas. On top of the bone and dental issues, they also develop benign skin tumors, like epidermoid cysts, across their body.
It truly is a whole body syndrome. And what about Turcotte syndrome? That one sounds even more severe.
Turcotte syndrome is a terrifying variant. It describes the combination of familial polyposis with the development of central nervous system tumors.
Brain tumors.
Yes. The most common CNS tumor seen in this specific presentation is a medulloblastoma. This is a highly aggressive, fast-growing brain tumor that typically strikes in childhood. So you have a young patient battling profound neurological threats at the same time their gut is carpeting with polyps.
Okay, we need to slow down and pivot to a topic that takes up a massive, dominant portion of the surgical guidelines. If you are prepping for your FRCS clinical viva, pay close attention because this is the ultimate high-yield topic, desmoid tumors.
Desmoid tumors represent perhaps the most frustrating, agonizing, and dangerous complication in the entire landscape of FAP management.
What are they exactly?
Clinically, they are technically classified as solid connective tissue tumors, essentially fibromas. They are overgrown scar tissue.
Now, I want to use my own logic here based on what we've discussed. You called them fibromas, not carcinomas, so they aren't cancer in the traditional sense, right?
That is the defining paradox. Unlike a malignant carcinoma like colon cancer or breast cancer, desmoid tumors do not metastasize. They do not break off cellular fragments, travel through the bloodstream or lymph nodes, and seed new tumors in the lungs or the liver.
Okay, so if they don't spread to distant organs, why do the sources explicitly state they are the second leading cause of death overall for FAP patients? How does a tumor that doesn't spread kill you?
Because they are incredibly relentlessly locally aggressive. They don't spread, they infiltrate.
Infiltrate.
Think of a desmoid tumor not as a solid ball that you can easily scoop out, but like the root system of an aggressive creeping weed. They arise in the connective tissue of the abdomen, particularly in a structure called the mesentery, which anchors the intestines to the back wall of the abdomen.
And the mesentery is full of critical infrastructure.
It is the superhighway of the gut. As the desmoid tumor grows, it wraps its fibrous tendrils tightly around everything in its path. It encases the ureters, which carry urine from the kidneys, leading to kidney failure. It wraps around the intestines, causing massive, life-threatening bowel obstructions.
Oh, man.
Most devastatingly, it intertwines inextricably with the mesenteric blood vessels that supply oxygen to the entire digestive tract.
So they just crush and starve the organs from the outside in.
Exactly. And because they are so deeply woven into the major blood supply, surgical removal is often practically impossible.
Yeah.
If a surgeon tries to cut the desmoid out, they risk destroying the blood supply to the entire bowel, which is a fatal complication. They're essentially untreatable surgically in advanced stages.
And how common are they?
They occur in roughly 10 to 15% of all FAP patients, and their unstoppable local destruction makes them a primary killer.
And is there a specific genotype link here? Just like with the retinal freckles, can we predict who is going to get these?
Yes, the correlation is very strong. Patients who have APC mutations located between codons 1395 and 2000 are at a significantly heightened risk of developing these aggressive desmoid tumors.
So if you're keeping track, we now know the enemy's exact genetic code. We know how it destroys the brake pedals of the cells, we know what it does to the colon, and we know everywhere it hides in the rest of the body, from the eyes to the brain to the mesentery.
Right.
The massive question now is, how do doctors find it before it is too late? Let's walk through the actual human experience of this. Let's look at diagnosis, screening, and the typical patient journey.
Okay, let's do it.
Imagine you're sitting in a clinic. You have a 12-year-old kid sitting next to you. Their parent, who is 38 years old, was just diagnosed with colon cancer, and the pathology reports confirm the parent has FAP. If you are the doctor, what is the very first thing you do?
The instinct, especially for a worried family, is to immediately draw blood from the 12-year-old child and test them. But structurally, scientifically, that is the wrong move.
Wait, really?
Yeah. The very first step is to focus entirely on the affected parent. You must perform a mutation search on their DNA first.
If you're listening to this and wondering why a doctor wouldn't just test the 12-year-old directly, it feels counterintuitive. If the kid is the one with their whole life ahead of them, why delay?
You have to remember how massive the APC gene is, and what we learned from that Spandito's case study.
Hmm.
The gene is huge, and the mutation can happen anywhere, even tens of thousands of base pairs upstream in the dark matter.
Ah, right.
Think of genetic testing, like searching a massive national library for one single book with a typo on page 50.
Mhm.
If you just send the 12-year-old's blood to a lab and ask, does this kid have FAP? The lab will do a broad, general sweep of the most common coding regions.
The standard street lamps.
Yes. And if that general test comes back negative, what do you tell the family? You can't tell them the child is definitely safe. You don't know if the child is truly negative or if your broad test just missed a weird, unique upstream mutation that is specific only to their family.
Ah. So you test the parent first because you know the parent has the disease physically.
Exactly.
Okay.
You know the parent have it.
Yeah.
So you sequence their DNA meticulously until you find the exact genetic typo causing the disease in this specific family line. It can take months of complex laboratory work.
But once you find it,
Once you identify the exact codon or regulatory region that is broken, you now have a highly specific, family-specific barcode.
and once you have the barcode, then you turn to the 12-year-old.
Yes. Now you can offer the child what is called predictive testing. You aren't searching the whole library anymore. You are telling the lab, go to chromosome 5, go to codon 1309, and tell me if this specific typo is there.
And the results of that predictive test carry immense psychological and physical weight.
They define the child's future. If the predictive test comes back positive, confirming they inherited the family barcode, the medical team immediately pivots into action. The child is enrolled in an intensive lifelong screening protocol, and prophylactic surgery is planned.
Well, what if they test negative?
This is one of the few moments of pure joy in genetic counseling. If the family-specific mutation is known, and the child's test confirms they do not have it, they are definitively cleared. The heavy cloud is lifted.
That must be an amazing feeling.
It is. They cannot pass FAP to their own future children, and their personal risk of colon cancer drops all the way back down to that of the general population. They are entirely released from the specialized FAP clinics.
But there's a giant, terrifying caveat to this whole process. What happens if the parent's mutation search is inconclusive? What if the 38-year-old parent clearly has a colon full of polyps, but the laboratory simply cannot find the mutation in their DNA?
It is a clinician's worst-case scenario. If the mutation cannot be identified in the parent, you have no barcode. Therefore, you cannot perform a reliable predictive test on the 12-year-old. In this scenario, clinical guidelines are extremely rigid. You must assume the worst.
So you treat them like they have it,
You must assume the child is at a 50% risk of having inherited the invisible mutation.
which means they can't be cleared.
No. They must undergo regular, invasive clinical screening, meaning physical colonoscopies, throughout their childhood and adolescence, just to be safe. We have to look for the polyps manually because the DNA won't give us the answer.
That sounds grueling. Let's outline what those routine monitoring schedules actually entail. Let's start with the child confirmed to have classic FAP.
For classic FAP, the guidelines mandate annual sigmoidoscopies, or full colonoscopies, starting at a very young age, typically around 10 to 11 years old.
10 years old. Wow.
Every single year, a gastroenterologist is sedating that child and passing a camera into their bowel, watching closely for the exact year those adenomas begin to bloom.
And what about attenuated FAP? The delayed timeline must change things.
It does. Because the onset of polyps in AFAP happens much later, you typically don't start endoscopic screening until the patient is around 18 to 20 years old.
That's a bit of a relief.
It is, but crucially, and this goes back to our anatomical discussion, because AFA polyps prefer the right side of the colon, a simple sigmoidoscopy that only looks at the lower left side is completely inadequate. You must perform a full, complete colonoscopy every 2 to 3 years.
And we can't forget the systemic threats. The surveillance doesn't stop at the colon.
Not at all. Extracolonic surveillance is intensely regimented. To monitor the stomach and the highly dangerous duodenum, patients undergo upper endoscopies starting around age 20 to 25.
And if the colon is already removed,
If they've had their colon removed, these upper scopes often start even earlier. They also undergo annual thyroid ultrasounds to catch papillary thyroid carcinoma, which is another associated risk.
the sources also mention a very specific screening protocol for young boys. What is that about?
Yes, for male children with FAP, particularly those under the age of 5, doctors must perform regular liver ultrasounds and draw blood to check their alpha-fetoprotein levels.
What are they looking for?
They are screening for hepatoblastoma, which is a rare but aggressive liver cancer that has a significantly increased incidence in very young boys with the APC mutation.
It is hard not to think about the psychological toll of this. Imagine a childhood defined by annual bowel prep, anesthesia, scopes, blood draws, and the constant looming shadow of cancer. But the clinical literature is absolutely crystal clear on the impact of this protocol.
It is the difference between a tragic early death and a full life. Unscreened, unaware patients die of metastatic colorectal cancer in their late 30s.
Right.
But with active screening, by catching those polyps while they are benign and acting definitively, survival rates mirror those of the general population. The heavy burden of screening literally buys them an entire lifetime.
But screening, no matter how rigorous, only buys time. It does not cure the genetic defect. Eventually, the polyps become too numerous, the dysplasia becomes too advanced, and the camera must be replaced by a scalpel.
That's the turning point.
This brings us to the surgical reality of FAP. For the medical professionals listening, this is where the FRCS clinical viva gets incredibly complex. This is the ultimate test of clinical judgment for top surgeons.
This is where rigid clinical guidelines crash into the nuanced reality of individual human lives. The very first profound question a surgeon faces is a matter of timing, when to operate versus when to keep managing it with a scope.
Right. What is the actual physical threshold that triggers the removal of a human colon?
If a patient has a manageable number of polyps, which is frequently the case in attenuated FAP, or in the very early years of classic FAP, gastroenterologists can routinely remove them during the colonoscopy.
Just pluck them out.
Yeah. They pass a tiny wire snare through the scope, loop it around the polyp, cauterize it, and pluck it out. They can clear the colon manually.
But there comes a breaking point.
Yes. Prophylactic surgery is triggered when the polyp burden simply overwhelms the ability to clear them endoscopically. The phrase often used is too numerous to count.
So too many to snare.
If a patient has more than 20 or 30 polyps that show advanced aggressive cellular changes, or if they have that literal carpet of over 100 polyps where you can't even see normal healthy tissue between them, snaring them one by one is physically impossible.
And there is a microscopic trigger too, right? High-grade dysplasia.
Absolutely. High-grade dysplasia means the cells in a single polyp look so chaotic and deformed under a microscope that they're practically screaming, "I'm about to become invasive cancer."
So that's the red line?
If even one single polyp out of hundreds shows hibular dysplasia, the watchful waiting is over. Surgery is mandatory. For a patient with classic FAP, crossing this threshold usually forces them into a major colectomy in their late teens or early 20s.
Okay, so the team has convened, the threshold is crossed, and the decision is made. The colon has to come out. Now the master surgeon has to choose how to do it. Let's walk through the surgical options. And from reading these sources, it seems like the entire strategic debate hinges on one specific organ, the rectum.
It really does.
Let's start with option A, total proctocolectomy with ileal pouch anal anastomosis. Most patients just call this the J-pouch surgery.
The IPAA, or J-pouch, is the definitive gold standard surgical operation for classic FAP. Total proctocolectomy means the surgeon removes the entire large intestine. The colon is gone, and crucially, the rectum is completely removed as well.
So everything high risk is gone.
All of the tissue that is at high risk for cancer is physically taken out of the body.
But you can't just leave the digestive tract unconnected. How do they reconstruct it?
The surgeon takes the very end of the small intestine, which is called the ileum, and pulls it down into the pelvis. They physically fold the small intestine back on itself and staple it together to fashion a reservoir that looks like a J.
Ah, hence the name.
Exactly. This J-pouch is designed to act as a brand new artificial rectum. The surgeon then connects this new pouch directly to the anal sphincter, preserving the patient's ability to go to the bathroom naturally.
If you're 20 years old facing this, what is the reality of living with a J-pouch? What are the pros and cons?
The massive life-saving pro is that you virtually eliminate the risk of colorectal cancer. The dangerous mucosa is entirely gone. You never have to worry about a colon tumor again.
But the cons?
The cons, the human cost, are immense. It is a massive, physiologically altering surgery. The small intestine is designed to absorb nutrients, not store stool like a rectum. So patients will experience permanent changes in bowel continence. It is entirely common for a patient with a perfectly functioning J-pouch to go to the bathroom 6 to 8 times a day, every day, for the rest of their lives.
That is a massive lifestyle shift. And the physical surgery itself carries risks to other systems, doesn't it?
Severe risks. Because the surgeon has to dissect deep into the narrow, crowded space of the human pelvis to remove the rectum, they are working millimeters away from incredibly sensitive nerve bundles.
Oh, wow.
There is a real risk of damaging the nerves that control sexual function and bladder control. Furthermore, in women, the severe scarring that occurs in the pelvis after the rectum is removed can trap the fallopian tubes, significantly impacting their future fertility.
And sometimes the J-pouch just doesn't work.
Yes, if the staple pouch leaks or gets chronically infected, a condition called pouchitis, or if the blood supply fails, the pouch has to be removed.
And then what?
In those cases, the patient requires an end ileostomy. The small intestine is brought out through the wall of the abdomen, and they will wear a permanent stoma bag to collect waste for the rest of their lives.
That is a brutal, heavy reality for a college-aged kid to face, which is exactly why surgeons desperately try to evaluate if a patient is a candidate for option B, total abdominal colectomy with ileorectal anastomosis, or an IRA.
In an IRA, the surgical strategy changes completely. The surgeon removes the entire colon, but they deliberately stop before they reach the pelvis. They intentionally spare and retain the patient's natural rectum.
Okay, so they keep the rectum.
Yes. They then pull the small intestine down and stitch it directly to the top of the retained rectum.
Leaving the natural rectum in place must drastically improve the day-to-day quality of life, right?
It is night and day. Bowel function is much closer to normal, true continence is preserved, and because the surgeon never has to dissect deep into the pelvic cavity, the severe risks to sexual function and female fertility are vastly lowered.
But I feel a massive but hovering over this option.
It is the ultimate surgical compromise.
Yeah.
You improve their quality of life, but the retained rectum is still lined with the exact same FAP mutated mucosa.
Right, it still has the broken brake pedal.
It is a ticking time bomb left inside the patient. Statistical long-term data shows that roughly 30% of patients who undergo an IRA will eventually develop aggressive rectal cancer down the line, requiring a highly complex secondary surgery to remove the rectum later in life anyway.
So if you're sitting across from an examiner for the FRCS and they ask you for the decision matrix, when do you actually choose an IRA knowing the cancer risk? What is the answer?
An IRA is generally reserved for very specific clinical scenarios. It is often the preferred choice for patients with attenuated FAP because their overall polyp burden is inherently lower, meaning the rectum might be relatively clear.
And for classic FAP.
It can also be considered for classic FAP patients if, at the time of surgery, they happen to have very few polyps specifically located in their rectum. But the golden rule is this. If you leave the rectum, the patient must explicitly commit to rigorous lifelong endoscopic surveillance of that remaining tissue.
I have to come back every year.
A doctor must scope that rectum every single year, without fail, to burn off new polyps. If the patient's psychology or their geographic access to healthcare suggests they won't comply with annual scopes, you cannot leave the rectum. You must perform the J-pouch.
I want to push back on something here, combining two things we've talked about. Let's talk about the desmoid dilemma. Earlier, we established that desmoid tumors are hyperaggressive, locally infiltrating scar tissue tumors that wrap around organs and are the second leading cause of death.
Yes, highly lethal.
You also briefly mentioned to me before we started recording that surgical trauma actually triggers their growth.
That is absolutely correct. The fundamental biological mechanism of a desmoid tumor is essentially wound healing gone rogue. When a surgeon cuts into the abdomen, the body detects the physical trauma and sends millions of fibroblasts to the area to knit the tissue back together and heal the wound.
Which is what it's supposed to do.
In a normal person, they heal the cut and stop. In a patient with FAP, because of the underlying genetic mutation, those fibroblasts can spiral completely out of control, continuously multiplying until they form a massive, aggressive desmoid tumor right at the site of the surgical incision.
Okay, wait. Let's think about this. The surgery to remove the colon is necessary to save them from 100% fatal colon cancer. But the physical act of performing that life-saving surgery might trigger a massive, untreatable desmoid tumor that crushes their organs and kills them anyway.
That's the reality.
What on earth do you do with that? It's the ultimate medical catch-22.
It is one of the most agonizing dilemmas in all of surgery. It requires a masterclass in risk balancing. If a surgeon knows a patient has a severe family history of aggressive desmoids, or if the genetic sequencing reveals that specific dangerous barcode, a mutation between codons 1395 and 2000, they will actively alter the entire clinical timeline.
So they don't operate, they just wait for the colon cancer.
They don't just wait passively. They pivot to aggressive delay tactics. They will delay the prophylactic colectomy for as long as safely possible.
By doing what?
They will rely heavily on intensive endoscopic control, sedating the patient frequently and painstakingly snipping out polyps by hand to buy time. They're hoping to delay the massive surgical trauma until the patient is a bit older, because data suggests the risk of a severe desmoid reaction can sometimes decrease with age.
And if they have Gardner syndrome?
If a patient presents with features of Gardner syndrome, like those jaw osteomas or skin cysts we discussed, the surgeon knows the underlying desmoid risk is sky high. The entire surgical plan is adjusted to avoid triggering that aggressive fibromatosis until the last possible safe moment.
It's just incredible. It's like performing surgery on a tightrope while juggling razor blades. Before we wrap this up, I want to bring in one last angle: pharmacology. With all these risks associated with surgery, can we just shrink these polyps with drugs? The sources devote significant space to investigational medical adjuncts.
Yes, the medical community has poured immense resources into finding pharmaceutical ways to manage the massive polyp burden. The most prominent successes have been with high doses of NSAIDs, non-steroidal anti-inflammatory drugs, specifically medications like Solondadac and celecoxib.
And didn't they use something else too?
Researchers have also utilized eflornithine, which is a specific enzyme inhibitor that interrupts cell growth pathways.
But let's be clear for the listeners. Are these drugs a cure? Can you take a pill and avoid the colectomy?
Absolutely. Definitively not. They are classified strictly as adjuncts. Clinical trials have indeed shown that these drugs can significantly decrease the total number of polyps in the colon and functionally delay their progression into larger, more dangerous adenomas.
But they don't fix the broken brake pedal.
Exactly. They do not erase the underlying APC genetic mutation. The beta-catenin is still accumulating. The NSAIDs might buy a patient a few extra crucial years before they inevitably cross that threshold and need a colectomy.
Which is helpful for the delay tactics.
It is a brilliant delay tactic, a vital tool in the surgeon's arsenal, especially when a surgeon is desperately trying to navigate the desmoid dilemma and delay surgical trauma. But they do not replace the eventual unavoidable need for surgical removal in classic FAP.
Okay, let's take a deep breath. We have covered an immense, complex landscape today. We've traced the devastating multi-generational journey of this disease.
We really have.
From a single microscopic biological typo in a strand of DNA, a broken brake pedal, a blind mechanic. We've seen how that invisible typo cascades into thousands of polyps in the gut, how it leaves hidden, ticking time bombs in the retinas of the eyes, the lining of the stomach, the bones of the jaw.
It's a relentless condition.
And finally, we've explored the intense, life-altering surgical chess match that patients and top-tier doctors must navigate together, balancing the lethal risk of cancer against the life-changing realities of a J-pouch or the crushing threat of a desmoid tumor.
It's a profound, humbling example of how deeply understanding the microscopic code of our genetics translates directly into making harrowing, life-saving decisions on the operating table.
Absolutely. Now, as we wrap up, I know you were looking at the broader implications of all this research, and you had a final thought that really reframes where this entire field might be headed.
Yes, we spent this entire hour discussing surgical delay tactics, snaring polyps, and removing entire organs to save a life. It is essentially highly sophisticated damage control. But the rapid advancement in genetic technologies, specifically CRISPR-Cas9 gene editing, points toward a radically different future.
Oh, wow.
Right now, FAP patients face a 50-50 coin flip of passing this broken APC gene to their children. But imagine a future, perhaps not that far off, where instead of planning a 12-year-old's first colonoscopy, we utilize CRISPR to literally edit the microscopic typo out of the DNA of an embryo in vitro before a single cell ever divides.
That would change everything.
We wouldn't be treating FAP by removing colons. We would be functionally erasing the disease from the human bloodline entirely. It shifts the paradigm from managing the inevitable crash to simply fixing the brakes before the car is even built.
What a profound thought to end on. Thank you so much for joining us on this deep dive. Keep questioning what you see on the surface, keep exploring the murky waters, and keep learning.